Jim was previously the Chief Executive of the South Central Strategic Health Authority and CEO of York Hospitals, NHS Foundation, etc. And I think I'll just leave it at that for now, and Jim, I'm going to turn it over to you.
Thanks, Jeff. It's a great pleasure to be here. When I make these short trips, my strategy is to stay on UK time, so it's 2 a.m. for me. So bear that in mind, and I'm going to talk very briefly and do an amazing thing, which is to talk to people without PowerPoint. This can be done, it is possible, and I'll do my best to do it. And I'm obviously going to focus on the issue of tonight, which is governance, and not just reprise the things that I said this morning, which I know some people heard, and others of you joined us tonight. But I'll do just the 5-second version of this morning to kind of set the tone for the governance question, which is that I believe that you, like us, your task is to lead big change. I don't think it's an option. You should always try and avoid leading change if you can. If there's an option to kind of just plod along doing the same, it's not a bad option, because change is a dangerous, difficult, uncertain place. But I don't think you've got the option. For us, it's really obvious. We're facing, as a country, a financial crisis. Healthcare is relatively protected, but for us that means the amount of money that we get in healthcare stays flat, and expectations, rightly, not from other people, from us, grow. The population grows older and more needs, our capability grows, and closing that gap won't happen by hoping it goes away. And your version's got some differences in how the economics work and how the timing works, but it's basically the same. And you are people, many of whom have made the direct choice to act as the stewards of the healthcare system in this part of Ontario. And for that, your job is to lead change, to sustain it now, and to sustain it for you and then your kids and their grandkids. So what you are doing is important, and you can't avoid change. Your only question is which change and how do you do it. And the point I was making this morning, and it's a difficult point, is that I think a big part of the change that you have to provide governance for is something that links together the ambition for excellence, the ambition for quality, with maturity about dealing with the financial issues. This is a deeply counter-cultural issue in healthcare. Great people in healthcare, great colleagues, believe that we should aim for excellence, but that it costs. That if you want things to be better, someone better put their hand in their pocket and find more money for it. That's, I've pushed that line myself for many years. I'm happy to provide you with shorter waiting times, or better cancer outcomes, or reduced deaths from heart disease, or improved mental health services if you find me 10 million or 100 million or £1 billion. Unfortunately for us, and I think for you too, that is becoming literally a bankrupt philosophy. And our leadership challenge is how we generate, do what every other industry does actually, which is to generate better and better outcomes within the resources available to us. But that points to your first challenge, which is you've got a challenge to change mindsets about the relationship between excellence and quality and cost. And it starts around the board table in terms of acting as leaders for a passion and a hunger for excellence, but at the same time a maturity and a realism. And people will try and tempt you, as they try and tempt me, into one of two camps. I've done a big interview for a national newspaper where they said, well, which is it? Which are you? Are you a hatchet man, or are you for quality? And I said, well, I'm trying to achieve quality. No. Which are you? And people, I think, will try and drive you and your leadership into those kind of very caricature camps, because they believe that that's the choice in healthcare. They believe it's different to any other enterprise in the world, that you are either aiming for quality, which costs, or you're controlling costs. And so our first leadership task as system leaders is to change that mindset and say, caring about quality means caring about cost. If you take decisions, if a great doctor, a great clinician takes decisions about the patient in front of them that don't have mind to the cost, that are wasteful of resources, then in your system like ours, a cash-limited, tax-funded system, in your system like ours, what that is doing is denying care to the patient in the waiting room. It's a direct decision to deny care to someone else when you make a wasteful and inappropriate decision to spend just on the basis of the person in front of you. Now, this is a big issue for wonderful medical colleagues. The great joy of my career has been working with those people. I'm sure it's true for you, but many of them were literally explicitly trained as young doctors that they should never think about cost. They were trained to think that they should just make the decisions about the patient in front of them and not think about the patients in the waiting room or the patients that we don't know about yet with diabetes or mental health problems in our community. I've had people say to me that they must think like that because it's an ethical issue. Well, you need to know my position is the reverse. My position is that in systems like ours, it is unethical not to think about cost and quality together, because you are explicitly choosing to deny care to someone else. And that the only ethical position for all of us to champion and boards to lead is that we care best for high quality and care availability for our community by caring about the two issues together. So I encourage you to think about how you help to lead that mindset change. I say it in the knowledge that at least in the first instance, this will not make you more popular. I guess you didn't join the boards necessarily to up your personal popularity. I guess many of you find you're constantly approached by friends and neighbours talking about challenges, so you kind of used that. My dad was, my much loved dad was the managing director of Black & Decker in the UK. He spent his life, people coming up to him parties saying, I bought this drill and it doesn't work. After 20 years of this, he got a great answer, which is, you should have bought a Bosch. We don't have that answer. And we shouldn't want it, should we? So you kind of understand that once you take this mantle on, our job is to see it through. But it's not popular, so as many of you know, the end of the talk I did today was accompanied by colleagues who I guess were great colleagues protesting about my appearance, with a kind of caricature of what are you doing bringing someone who's cutting a system somewhere else to talk about change in Ontario. Well, I understand that's about passion and engagement. There's probably a good, healthy thing. But it tells you that, in fact, we went outside to try and chat to people. No one was very interested in actually having a conversation, because the issue was that what people wanted to perpetuate is a stereotype, which is that if you're talking about controlling money, you're the enemy of quality. Well, don't believe it. The way you sustain and value and cherish and build quality for the people of South West Ontario is to make sure that the issues are linked, because that's the way you provide great, safe, sustainable care. And by the way, the solutions to the two are the same. It's the same failures in quality about harm to patients that are costly to the system. It's the same waste and duplication. It means that all the evidence tells us around 30% of the time of our highly valued professionals is time wasted. It's the same thing that gives them back their jobs as being nurses and doctors and being professional that also deals with the efficiency. So please champion that connection. We need you to do it, but it will involve you in people wanting to stereotype what you do. But it's worth it. I think we have a similar system in England of non-healthcare professionals joining boards, and I've worked and love working with those people for many years. We do pay them, by the way, we pay them an insulting amount. So maybe it's better not to be paid. So, and it's a real challenge for those board members to be champions of these things. And so I'll just share some reflections about that. You cannot overstate how powerful medicine is. And it's a really difficult thing, even for people like you with fantastic careers in industry, in the voluntary sector, in your communities, that when you see an issue and you're not happy with it around the board table and you raise it, and the power of the medical machine tells you you're wrong, it's a very difficult place to be. And I encourage you to remember that that's exactly what you're for. Let me tell you a story about when I was the chief executive of York Hospital, which was a very good hospital, had wonderful staff. It's a great privilege to work there, and we did very well in all sorts of evaluations because of the work of those staff. But we had an incident, a series of incidents in which 3 times over the course of 18 months during ophthalmology operations we put the wrong lens into people's eye. It wasn't catastrophic for those people, it could be sorted out, but 3 times we made the same error. And we discussed it around the board table, and we had a recently appointed board member with a background in quality in industry who was absolutely horrified, rightly horrified, and said, I just cannot understand how 3 times we've made this harmful error to people. And I heard my medical director, who was a wonderful, committed, passionate colleague, supported by me, explain in as patronising a way as we could that there is a normal error rate for cataract operations. Our overall performance is well inside that error rate, that whilst these were disappointing occurrences, they weren't catastrophic and they were easily solved. And I had that dreadful experience of suddenly kind of being out of body and hearing myself defend these dreadful failures as though it was okay. But we would have won that argument with that non-executive colleague, because the power of a senior doctor supported by all the machinery of management is a pretty intimidating thing. But the reason we bring colleagues onto boards is to provide exactly that frame of reference. When you're a chief executive or a doctor in a hospital or another facility, your problem is that you lose the ability to see your own facility in perspective. You lose the ability to see it. The most powerful way you learn that, which has happened to me, is when you become a patient of your own facility. And all of a sudden, when you cross the curtain, when you're on the other side of the stage, you realise it's completely different. You can't see it. We've become blind, we're institutionally blind to our own services, not because we're bad people, because that's what it does to you. And you need to hold on to the remarkable gift you bring of bringing an outside perspective in. And the challenge you bring with no knowledge of the detail of cataract surgery is at least, as I would say, more important than the institutionalised view of what represents harm in cataract surgery or anything else. So it's a very precious thing, but it's a difficult thing for you to do, but I encourage you to do it, because people like me and my medical and other clinical colleagues need you to do it, otherwise we will sleepwalk into harm and failure. And you're the conscience, you're the people who keep us awake. So it's critical. Let me go back to this issue of having a lot to do and offer some kind of pretty lightweight personal reflections on where I've seen boards do that really well. And what's made a difference. It's very interesting when you talk about tough times. Everybody talks about tough times and making tough decisions. People slap themselves on the back about, we're going to take tough decisions. I go in and see my Secretary of State for Health, who says we need to take clear, tough, decisive action on things. The problem is everybody is in favour of taking these decisions in principle. It's just when you have to do it in practice that people don't like it. And that's when the board earns its spurs. Because this isn't something that we're going to achieve in principle. So you talk about changing care to be out of hospital, you can get nearly everybody to agree that that's a good thing. That's been our experience. But when you begin to work through the consequences, which is that we're going to move people's work from one place to another, we're going to change people's working practices, their hours of work, their training, different professionals are going to be doing different things, and hey, by the way, we're not going to keep those beds open that we don't need anymore, because that's a shocking waste of resources. We're going to close those hospital beds. Then you start to see support draining away. And for every decision that people support in principle, the corporate act of making that happen is fraught with difficulty and disagreement. Now, of course, you need to do that well and communicate with people and respond to real issues. But at the end of the day, only you can follow it through. Everybody else, turns out, is just a commentator. We got, as we try and go through this big change, we got in there as kind of various think tanks in England, healthcare think tanks who do these great kind of analyses, and we got them in. And we said to them, you're brilliant people, you do this great commentary, we're facing these problems, what would you advise us to do? Well, the silence was painful. One of those meetings where you could hear the clock ticking ever louder. And it turns out there is a difference between commentary and being a player. And there's a reason that some people are in the commentary box and some people are on the ice. and it's because some people are prepared to take the action and the criticism that goes with it, and other people just want to be commentators. It's not hard being a commentator. It's not hard running the most successful team from the commentary box. The real action is on the ice, and you've chosen to be there, and it means that you won't always find it easy or popular, but it's the only place that you score from. And so following through from that agreement in principle through difficult times, to kind of taking that action to help staff to move, to deal with the union anxieties, where that's the right thing to do, to close the beds that go behind it, to move money around in the system. That's the stuff that only you can follow through and make happen, and the only stuff that will be sustainable. And again, it's precious because it's the difference between commentary and being a player, and in case you haven't spotted it, you're players. The other really interesting thing about being tough, this is a sort of lesson I've learned, is you have these conversations with people, so we're going to do this, it's going to be tough, and everyone agrees. And then it happens, and it is tough. And it's as though you've never had that conversation. People say, I can't understand what's going on, this is terrible, it's so difficult. There's sort of collective amnesia about the fact that you knew it was going to be difficult. So the way I deal with it now is that I say this, I say, we're going to do this, it's going to be really tough. My guess is in about September it's going to hit, and it's going to be really horrible. When that happens, we should remember that we had that conversation. So what happens is that we now do the change, it gets to September, it's awful, and people go, I can't believe this, it's terrible. And I say, don't you remember we had that conversation? And I said it was going to be tough, and they say, oh yeah, I can't remember that, but I didn't think you meant this. It's a natural human reaction, which is that when it gets difficult, people are anxious, they're frightened about a whole series of things, very basic personal things. What does this mean for my job, and my, paying for my kids' education, or whatever it is. And again, it's the moment when the leadership of things like boards really matters. All boards, most boards, are brilliant at setting out a vision for the future, where you really make a difference at every level, from strategic, from talking to the media, to going down to the front line and talking to people, helping them go through the change. That's where people really notice the difference that boards make. And when it's tough is the time to be present. And you should never minimise the personal difference you can make in just spending time with people, how much they value and recognise that you giving your time to talk to them in those difficult moments, to listen and reflect people's views, but hold on to the end point. It's very valuable. I used to think that when times were tough, if I went and spent time with people, they would just find it irritating. They would just think I was in the way. My PA used to say to me, are you going on another one of your morale-lowering tours around the hospital? I'm pretty sure she was joking, but not 100%. And I that was my thought, when it's tough, the last thing people need is someone, wandering down. In fact, and I'd go down and talk to people, I don't really think I did any good there. People were unhappy, I listened, I reflected why we were doing things. It never produced a big conversion moment for people. But the feedback you got about the difference it made, that when life was really tough, the fact that you were prepared to find the time to listen, but hold on to the values and what you were trying to do, makes a huge difference to people. And again, I know you do this now, but I really encourage you to do it. I think you've got some really difficult things to balance in the change. And it is a balance. They're not, again, I think people will tempt you to be one or the other, and I think you have to find a very complicated route across the, mixing about 100 metaphors here, across the tightrope. There's a very difficult, Jeff talking very powerfully about community engagement, and of course you need to build what you're doing on community engagement, but in my experience that rarely translates into consensus around the action that's needed. So people will talk again about out-of-hospital care being a good thing, but when you say we're taking those 6 beds out of this local facility, which is much prized, all of a sudden that becomes very contentious. And so there's a really difficult balance between engaging people, listening, trying to bring people on board, but also recognising there's a point where consensus hasn't been reached, and you are the people, you are the only people who can make a decision. And making a decision is a really important thing to do, and following it through. And you'll bring some of those people that you engaged with you, but others, like the colleagues around this morning, will be protesting that you failed to understand. It's particularly difficult, I think, as many of the changes you're talking about are removing some of the physical symbols of healthcare and replacing them with things that you can't see as easily. In England, it's absolutely clear that one of the reasons that changes to hospitals are so difficult is that hospitals are a physical embodiment of what healthcare means for people. When you drive past your local hospital, it gives you a sense of reassurance that if I'm clutching my chest, somebody will be there to care. It doesn't matter what the reality of what goes on behind those doors. It's a powerful physical symbol. And when you replace that with community services, it's much more difficult. I think one of the things, again, you can do is think how to make visible, apparent on the media, in the way you describe them, in the way you label buildings and services, that those things become as powerful physical symbols. So balancing engagement, but your job to make a decision. You've got to balance the views of the patient and the views of the professional. My most powerful experiences of this have been in mental health. In mental health, it's an incredibly difficult balance between an often very empowered patient group who have clear and varied views about what the right care is, and professionals who maybe have a different view and sometimes need to take decisions that patients actively disagree with about what is the right care for them. But it's true in many other services as well. And again, I think you'll be working through that balance. For you, the risk, I think, is always that you'll get dragged towards the professional view. Professional views are important and we need to engage them, but our job is to serve patients. When you're asked to make a call between the two, we should always try and find a way of coming down in the interests of the patient, not in the interests of the professional. In England, for all, people have been very generous today about the gains we've made in England, and we're proud of some of them, but we've still got a huge way to go and look with admiration at much of the work you do. But the harsh reality is that in England it's still the professional voice that dominates. We still run services hours to suit us and expect patients to turn up when it suits us to do it. We still expect patients to find their own way through the pathway because professionals won't work together as effectively as they could or should to make that work. And again, I think one of your jobs is to bring the real, undeniable voice of the patient to the heart of the boardroom and make that the base of what you do. Bringing those direct voices in is a remarkable thing. When I was the chief executive of the hospital, I discovered after about 9 months that there was someone whose job it was to keep difficult patients away from me. So when patients have a problem, one of the first things they would say is, I want to see the chief executive. And we employed someone to keep them away from me. It was an extraordinary thing, and obviously it was easy to change. And I met a small number of patients who seemed to be very confused and unhappy, but mostly I met patients with the most powerful stories to tell me about what we needed to change in our system. They were, without a shred of doubt, the most powerful conversations I had as a leader, and bring those into your boardrooms without people modifying them. Bring them directly into the heart of your work, and they'll sometimes be uncomfortable, but they'll be an enormous vehicle for change. And you've got to balance this very difficult issue about local and kind of central, where you should do things once and where you should make it local. Everybody wants everything locally, and we can't do it. And the driving principle for that should be quality, what will save most lives and make people. So these difficult balancing acts where, again, you are the people who have the power to make a decision that will be the right thing for patients. So finally, just something very quickly about governance. I don't know as much about governance as many of you. I kind of, for me, the term sometimes makes me shudder, because in England, one of our bad habits is developing a governance industry, which isn't always the same as providing great governance. In fact, it's sometimes the opposite. Whenever I see a 40-page risk register, I'm relatively convinced that people have lost the plot on governance, because we've created a bureaucracy, not empowered people to make the right decisions. So making this real and living it out, but not getting tied down in endless processes would be my prejudice about what you should do. Good governance is a culture, it's something you live, not something that you give to an administrator to provide for your board. It's something that happens between the members of a board in the way they act and behave, not something that's imposed as a structure around a board. For me, great governance is the frame in which you allow great leadership to happen. That's the job. Great governance is the frame for great leadership. And so if you just ask me to say something about what I, as a chief executive, feel I've gained most from boards, it's very simple. But again, perhaps a bit paradoxical. When I've gained most as an executive from my boards is that combination of challenge and support. People who are prepared to make me work really hard to explain why we need to do the things we need to do. And when they think I'm trying to slide away from the issue or blind them with kind of technical stuff or look down my nose at them and say, we're not having it. If you want us to back this decision, we need to own it together. And I'm not going to let you get away until we do that. So that kind of relentless challenge. But once we'd reached the shared point of knowing that what we wanted to do, we're just never ending in their personal and political and organisational support for making it happen. Who were prepared to back it, provide support when it got sticky, put their hand on my shoulder and say this is still the right thing to do. And if we ran into real trouble, we're also the people who would say, but Jim, don't take yourself into a corner here that you're never going to get out of. You know, we need to be able to think through what we need to do. So it's a really complicated balance of high challenge, high support environment. From what I've seen and read in preparation for today, you're in an incredibly privileged position with the opportunity you have and the leadership you have in the Southwest. Some of the work that I've seen you doing stands up with the best in the world in terms of commitment to quality improvement and making things happen. For all that, I think you're in the same position as us, which is that just carrying on at the level you are will turn out not to be enough. And for us to provide sustainable healthcare systems for us, for our mothers and fathers currently, for us soon, for our kids, we all have to up our game. And your leadership role in that is really going to be fundamental, and I know you feel the same. And I wish you just huge success in providing that leadership in what we've said a number of times today, but is of the most important public institution in your country. Thanks very much indeed.